International Fluid Academy. I'd like to first thank Prof. Manu Malbrain and Xavier Monet for being with us here in Kuwait. I'm very excited about establishing the Kuwaiti chapter of the International Fluid Academy. There's so much, the title maybe is not fair for the content that will come throughout this day, but I'm very happy to have them both here and having our team from Emiri Hospital supporting some cases later on. And I hope you have a great day and enjoy the whole program that we have for you here. And I will hand it over to Prof. Malbrain for opening the rest of the program and taking you through it. Thanks a lot.
Thank you so much, Dr. Abdulrahman Alfares, for the kind invitation. So when he invited me to come and speak at the PANORAP meeting, we discussed why not launching the International Fluid Academy chapter in Kuwait. And this is why we are here today. So the idea is to have interaction. Please interrupt us whenever you want, raise your hand, and ask any question you'd like. Okay, so we might better kick off. And I will start with a 10D framework on fluid stewardship. I'm not sure whether the remote is working. Okay. Now it is. So we're here in the beautiful city of Kuwait, and together with Professor Xavier Monet from Paris, France, we will be your host today. There's a bit of an overview of the program, some general topics on fluid stewardship. Then Xavier will talk about the hemodynamic monitoring, about fluid responsiveness, and then the floor is open to you to ask us any questions. So after that, we move a little bit more in depth with some monitoring tools, looking at the dangers of fluids like fluid accumulation syndrome and how to reduce cumulative fluid balance. Then there is a lunch break, and after that, we will have some display here, and we will show you how to do a bioelectrical impedance analysis measurement, some patterns of shock recognition, a VEXUS score, how do you do this, and a proper passive leg raising test for fluid responsiveness. And then there is Alfares who will present a Kuwait case, a patient with septic shock, and we will take you through all the phases within the ROSE model with a resuscitation, optimization, stabilization, and evacuation phase. And then the final session, we have the president of the World Federation Intensive Care, Jorge Hidalgo, who will close with the future of artificial intelligence. So at that end, we will have the post-examination test. And for the winners, I brought some fluid books. So if you just pay attention, you don't fall asleep, you will pass the exam and maybe get a book. So I'm an internist, intensivist, coming from Belgium, and now I'm working in Lublin in Poland for critical care research. I've been ICU director and even medical director in many hospitals. But now I basically enjoy spreading the knowledge on fluid stewardship. These are my conflicts of interest. So let's start with a brief introduction. Why are we giving fluids? Well, you may want to give fluids to promote stroke volume or to increase tissue perfusion, because it's all balancing the macro versus the micro circulation. Cardiac output is key for the macro hemodynamics, but we know that sepsis is a time-critical emergency. And in medicine, we have many time-critical issues like myocardial infarction, ischemic stroke, polytrauma. You need to have a full-body CT. And in sepsis, we have a 1-hour window to give the right antibiotic and to give the proper fluids to resuscitate the patient. So maybe we have an opportunity and a golden hour to do good. The reason why we are giving fluids is like deeply ingrained in our brain and comes from the blue stage of spasmodic cholera, where we saw that these patients are profoundly hypovolemic and fluids are life-saving. Yet we know after you give a fluid bolus, the effect on stroke volume fades away after a black screen. So only 30 minutes, you have a volume expansion effect, and then you will see that cardiac output drops again. And from other studies like the Andromeda trial, we found that initially about 60% of the patients in sepsis are fluid responsive. But after 2 hours, 4 hours, you see that this number decreases to maybe 4% only, saying that fluid responsiveness is usually there at the very early stages of profound shock, but after 1 hour, 2 or 4 hours, it may fade away, and then the risks of fluid accumulation may increase. So after 30 minutes, even responders, non-responders go back to baseline, and in the Andromeda study, after 4 hours, you only have 4% patients who are fluid responsive. That's why we need to check it, and to check whether they're responsive or unresponsive. So, the reason why we give fluids, you only should give them when the patient has acute circulatory failure, shock. When there is tissue hypoperfusion, you can do a capillary refill time, you can do lactate, and the patient should be fluid responsive. Xavier will tell us everything about that. Then we need to check whether the patient is fluid tolerant. Maybe my battery is... So the patient should be fluid tolerant. And fluid tolerance is a new concept, which is the maximum amount of fluid we can give without causing harm. So we don't give fluids if there is a potential for harm. And finally, we check for risks. Is the patient at risk for fluid accumulation? To check for potential adverse effects, electrolyte disturbances, acid base, and the accumulation of fluids. Only if these 5 conditions are present, you're safe to go to give fluids. Fluid accumulation syndrome, there will be a lecture dedicated to that afterwards. As the word it says, it's a syndrome. It's not a disease. It can occur within many conditions and disease states. And I have to share you a testimony. It's my personal testimonial as a patient. What you see there is an ugly bag of unbalanced saline solution in glucose. And I asked my wife to take this picture when I was receiving this ugly bag. And this is my abdomen after 2 days of the surgery. There is pitting edema, and I gained 8 kilos of water. So I had fluid accumulation, and I also had intra-abdominal hypertension because my bowels were not moving, ileus, because of the opioids. And I can tell you, it's terrible. It's terrible if your abdomen is distended due to fluid accumulation and you can't breathe. So it is real. And typically you see when the abdomen is distended, you see an upward shift of the right diaphragm, and there you see the ileus with the air in the stomach. Of course, everything went well. I'm here talking to you, but the question is, are we shifting our mindset and are we thinking fluid stewardship? So today is about breaking some bad habits. And that's why about 15 years ago, we created this International Fluid Academy with colleagues from France, UK, Netherlands, and Belgium. And the mission statement is to promote research, foster education on fluid management, and thereby hopefully improve patients' outcome. So it's all about education, research, and collaboration. I invite you to join the members portal, and we have now over 5,300 members. The website is highly trafficked with over 1,300,000 unique visitors. And one of the reasons I got an interest is when I was a medical student, I exactly received 0.0 hours of education and training on fluid stewardship. Yet, 1 patient in 5 will suffer from deleterious complications of inappropriate fluid management. And this may be too little fluids when it's needed or too much fluids when they are no longer needed. So we should look at fluids in the same way we look at antibiotics: drug, dose, duration, de-escalation. So we conducted a worldwide survey with Prashant Naza as the first author, and we had over 1,000 healthcare providers. And you know what? The average score was 46%. We did not pass the test. And if we would run the survey in your hospital or in yours, probably the results would be the same. So there is a lack of knowledge, and maybe also a lack of awareness that fluids are drugs. When we do these IFAT minis and take a good look at this question, maybe it comes back later at the end in the exam, but if we ask colleagues, what is the ideal maintenance solution? And you see, most of them vote for a balanced isotonic solution, whereas a hypotonic solution, according to the NICE guidelines, is the best option. We make mistakes. We are humans. To err is human, but let's forget the mistake and remember the lesson: to break some bad habits. So with the Fluid Academy, that's why we set forth to sit down and write some guidelines on fluids in sepsis and fluid stewardship, perioperative fluids, fluids in COVID patients. We also promote the research, like the studies on maintenance, the MIMOSA and the TOPMAS trial. And now we find that the problem may not be the fluid load, but the sodium load. And a positive sodium balance may lead to a positive fluid balance. Fluids in abdominal hypertension, one of my favorites, and a latest paper on how to implement fluid stewardship at the bedside. I'm very happy and proud to share with you that the open access book on rational use of IV fluids, and you see there are some copies over there, has been downloaded 1,270,000 times. 1,270,000 times. Tells me 2 things. 1, people like it when it's for free, of course. 2, it tells me that there is a need to understand and learn more about fluid stewardship. And that's why we are here today. So after COVID, that was before COVID, we had this kind of fluid meetings like today here in Mexico. We were in Sao Paulo in Brazil. And then after COVID, we kicked off again with some meetings in Sumatra, in beautiful Bali. And this year we had IFAT minis in Dubai, Joburg, Kuala Lumpur, Sao Paulo. And you can see always at the end of the day, you got a picture, we have a group photo. This was Johannesburg, and everyone always looks quite happy. So now it's a bit serious, but at the end of the day, things will get better. This was this October in Abu Dhabi, and then there was a meeting again in Sao Paulo. We are a specialist society of the European Society of Anesthesiology Intensive Care, and also there we have Fluid Academy sessions, and the rooms are always crowded, as you can see here. And this is the list, and I'm very happy that this meeting in Kuwait is the first of this year, after which we will visit other countries. So today we're talking about stewardship, which is the diligence, the carefulness of treating fluids as drugs. And to simplify, I've prepared a 10D framework. D1 is definitions. We need to speak the same language and use common definitions for volemia, fluid responsiveness, and so forth. D2 is the diagnosis. How are we going to diagnose volemia, fluid unresponsiveness, impact on organ function, and so forth? D3 is distribution. Every fluid administered will be lost to the interstitium. It's just a matter of time. D4 is the drug. D5, the dose, like we know from antibiotics. D6, duration of treatment, stop when shock has resolved. D7, de-escalation, come down with the speed and the volume of fluids as the patient stabilizes, switch to oral fluids. D8 is documentation, and that's, I'm looking at the pharmacist, we need to look what we are doing. What is the issuing of the fluids in your hospital, in the ICU, in the emergency department? How many saline are we giving, and so forth. So look at the numbers. D9 is the diligence, is the stewardship, and D10 is the discussion. Discussion, because I couldn't find a word with the D that comes with leadership, is about the change management, the transformation. Because doctors don't like to be told what they need to do. Probably some of you are still giving saline. And if we need to change from saline to ringers or a balanced solution, they ask why? Why should I change? I have done this all my life. So the discussion goes about leadership and transformation. So when you have D1 to D10, you multiply, you have D to the power of 10, and this is what I should call fluid stewardship. This is what you and you should be doing in the ICU in the hospital. So let's dive into this quickly with D1 on definitions. And the first chapter of the book is a 40-page chapter with just definitions, a boring list of definitions just to understand, and we speak the same language. We know of fluid balance, and are there any nurses in the room? Could you raise your hand? A nurse? Okay, fantastic, because the nurses are key, important to collect and calculate a daily fluid balance, the ins and the outs, and you have it in a cumulative way. Fluid overload, you look at the cumulative balance, you divide by the baseline body weight, and you have a percentage of overload. And initially was defined as a 10% cutoff. And now there's a new definition on fluid accumulation we will discuss later. Early adequate fluid management in the early stages of sepsis, patients are fluid responsive. You have the guidelines like the surviving sepsis, the 30 ml. We will discuss whether it's appropriate or not, or you can give a fluid challenge, 4 ml per kg. Late conservative fluid management, 2 consecutive days of a negative fluid balance within the first week, and then late goal-directed fluid removal. We will discuss this during the case, is, I should call it de-resuscitation, because it's active intervention with diuretics or ultrafiltration to remove excess fluids. So fluid accumulation syndrome has an impact on all organ functions. And there are many more definitions, but for time's sake, we will move on to D2, which is the diagnosis. Diagnosis is key. Is my patient hypovolemic, hypervolemic, fluid responsive, and so forth? Hypovolemia is bad because there is a convective problem and oxygen can't get to the tissues. But hypervolemia may even be worse because there is a diffusion problem and oxygen can't get to the tissue. Interstitial edema, like I showed you my abdomen. Intra-abdominal pressure may increase because of bowel edema and ileus. So prediction of fluid responsiveness, and I invite you to have a look at this paper written with Xavier and Michael Pinsky on different modalities, and Xavier will list them during his lecture on how to assess fluid responsiveness with the mini fluid challenge, the passive leg raise, and expiratory occlusion test, looking at ventilator vascular interactions. So fluid responsiveness is important, and it can be accompanied with a preload or volemia status that is either very low or very high. At the other end of the spectrum, the fluid accumulation can be accompanied with edema that is very pronounced or very little, and in between, I told you about the fluid tolerance, the maximum amount of fluid that we can give without causing harm. So if a patient becomes fluid unresponsive, if there is venous congestion and hypertension, he may become fluid intolerant. But the problem is, when you look at volemia, fluid responsiveness, fluid tolerance, tissue perfusion, these parameters can be in any possible combination. So you can have a patient who is hypervolemic, fluid responsive, still fluid tolerant, but with tissue hypoperfusion. So these are the tricky cases where we can have therapeutic dilemmas. And the interplay between fluid responsiveness and fluid tolerance may determine the risk for fluid accumulation syndrome. And to complicate things, in this study by the group of Philip Rolla, who were the first to define the VEXUS score, the venous congestion by ultrasound assessment, they found that in patients who are fluid responsive, some of them already had grade 1 or 2 venous hypertension. So fluid responsiveness does not mean that you're also fluid tolerant, to complicate things further. So the fluid status is very important, but there are many myths and misunderstandings surrounding this. Not all septic patients are hypovolemic. At a very early stage of sepsis, they may just be vasoplegic. And there is this misconception on the stressed and unstressed volume. Look very good at this slide, may come back for the exam. I'm just giving some clues here and there. And this video nicely demonstrates if you would give norepinephrine, you squeeze the vascular bed, you recruit stressed volume from the unstressed, and you improve venous return. So it's a kind of auto-transfusion effect and a synergistic effect. It's not because there is peripheral edema that we need to give diuretics. And it's not because preload is low that we need to give fluids. Just because you're fluid responsive also does not mean that you need fluids or that you are hypovolemic. It's just how you play with the ventilator. Or that you're fluid tolerant, as I showed you. Those are separate parameters. So it's all about going back to the initial reason why we are giving fluids, to increase stroke volume, but also to have a mean arterial pressure, because we have the CVP at the backhand, or the mean systemic filling pressure, better as the venous return. At the level of the organs, we have perfusion pressure. And this pressure is important for organ function. So we have the preload on one side, the afterload, and the contractility, but important at the level of the organs is perfusion pressure. And in the case I showed you, when abdominal pressure is increased, abdominal perfusion pressure will come down. And this is why the kidneys are very vulnerable to increases in back pressure. And maybe some colleagues, like in Holland, they say to give nitroglycerin to lower diastolic pressure and to increase perfusion pressure at the level of the organs. So D3 brings me to distribution. I told you all fluids are lost. It's just a matter of time to the interstitium. And for that, we need to understand the difference between osmolality and tonicity. Osmolality, you know the formula. This will determine the tolerability of an IV fluid. But if we look at effective osmolality, or the tonicity, which is mainly driven by the sodium, this will determine the distribution of the fluid. So what does it mean in practice? The body is mainly water, 66%, and most of the water is intracellular, 2/3. Out of the extracellular water, 1/4 is the intravascular fluid, the rest is the interstitial one. So if we are giving fluids to resuscitate, we want the intravascular volume to increase, the circulating blood volume. But what happens if I give 1 bag of saline and I check after 1 hour what is happening with 1 liter of saline? Only 25% will remain intravascularly. Okay. If I would give a hypotonic solution like glucose or dextrose, after 1 hour, only 8%, and the rest would be intracellular. So hypotonic solutions are very good for cellular dehydration. And if I'm giving a colloid, which is isotonic, I assume at least for 1 hour it will remain intravascularly. For albumin, half-life 4-6 hours, so at least you have a longer volume expansion effect. D4 is the drug. We should not harm our patient, and we need to ask ourselves 4 questions. So the first question is, when to start fluids? Second question, when should I stop them? Third question, do I need to remove excess fluids? De-resuscitation. And the last question, when you're removing, when should I stop removal? Because you want to avoid hypoperfusion again. So we need to find answers to all these questions. But there are only 4 indications to give fluids. 1 for resuscitation, to save lives. And this is summarized in the 7 R's. Second is for routine maintenance, to cover the daily needs of sodium, glucose, water, other electrolytes. Third is replacement. It should mimic the fluid that is lost. And this may be one of the indications of abnormal saline. If you have a lot of vomiting and you have metabolic alkalosis, then you could use saline if there is upper GI losses. Also in traumatic brain injury. Fourth, I had to play a little bit because nutrition is not an R, so it's re-energizing fluids to cover the daily caloric needs. But if the gut works, we should use it. The fifth, it's not really an indication, but a consequence, is fluids that seep into the patient to dissolve other drugs in antibiotics, painkillers, antacids. Remember, all fluids are redistributed, so we have to reassess volemia and fluid responsiveness. So in this study conducted by Niels van Regenmortel, 15,000 ICU patients, they found that from all the fluids administered, 3% were blood products, 6% for resuscitation, 25 maintenance replacement, 33 nutrition, and 33% fluid creep. These are the little bags of saline that we use in the ICU to dissolve noradrenaline, dobutamine, all other drugs that we need to administer. So if you look at the creep and the nutrition, it's a lot of fluids. So this means that maintenance is usually not needed because patient receives enough other fluids to cover the daily needs. Some years ago, 10 years ago, there was the big debate between colloids and crystalloids. Now it's between saline and balanced. So balanced crystalloids like Ringer's lactate, Ringer's acetate, Plasma-Lyte versus saline. And over the years, we had a lot of studies, started with the SPLIT, the SALT, the SMART, BASICS and the PLUS trial, covering almost 30,000 patients, and the discussion goes balanced versus saline. Take a very good look at this slide, maybe. Strong ion difference is 0, meaning that if you administer saline, you will cause hyperchloremic metabolic acidosis. Buffered solutions should have a strong ion difference 24, 26, so above the ideal one to keep acid base in balance. And that's why we need to add either lactate or acetate or gluconate to increase the strong ion difference. Just recently, a systematic review of all these fluid trials have been summarized, about 34,000 patients, and the bottom line is that balanced solutions have a 1% beneficial effect on mortality, ranging from a 9% benefit to 1% increase, with a 90% probability. And it's associated with less major adverse kidney events after 30 days. And if you combine the trajectory of the patient in the emergency room and the ICU, so balanced in the emergency, balanced in the ICU, and further on, the impact was even greater. And in these studies, they looked at pre-randomization fluids that the patients were given. Also in sepsis, burns, diabetic ketoacidosis, even renal failure, but not in TBI. And I told you upper GI losses, there saline is a first choice. So if you look at 1 bag of saline, it's about 3.5 grams of free sodium. The dietary requirement is 2.3 grams of sodium per day. So 1 bag of saline is already too much and is a lot of salt. So I would not call it normal. I don't know why they call it normal saline. We don't talk about normal cefazolin or normal albumin. It's like an excuse to make something abnormal looking normal. So skip the normal and just talk about saline or call it abnormal saline because it has dramatic effects on lots of organ functions and metabolic things. Just to name a few, it causes hypernatremia, hyperchloremia, hyperpotassium because of the hyperchloremic metabolic acidosis. The sodium balance will be positive, so it leads to fluid accumulation syndrome, and it has an impact on kidney perfusion, kidney function, and the need of vasopressors. So it's not normal if you would administer it beyond 2 liters in a week. So what is the ideal fluid? I don't know either, but I think the big bags of 5 liters that we use for hemofiltration, substitution fluids, they come closest to plasma. Problem is we can't administer them intravenously, only via the extracorporeal circuit. So the ideal or the normal strong iron difference to keep pH neutral is 24. Saline has 0, plasma light has about 50. So in a healthy patient, plasma light may induce metabolic alkalosis, which is not the case in a patient with septic and lactic acidosis. So the ideal crystalloid, the discussion probably in the next years will go on the buffer, the balancing. And we can have different buffers like lactate, pyruvate, acetate. But the misconception about the buffer is that the perception is that this is to create bicarbonate or to substitute bicarbonate, but it's not a precursor. It's not to generate bicarbonate, but it has to disappear as rapidly as possible within the Krebs cycle to increase the strong iron difference and to improve acid base. So D5 is the dose. And Paracelsus nicely stated, everything is poison. It's just the dose that makes something to become poisonous. You can have free water intoxication. If you would drink 10 liters of water like this in half an hour, you would get poisoning. So the dose is important. And in these studies, because most of the data is done in resuscitation, we looked at maintenance solutions in healthy volunteers and in ICU patients. Healthy volunteers were ICU nurses locked in a hotel like this one, and they just received bags of maintenance solutions, either saline or hypotonic balanced maintenance. And you can see that after 2 days, the sodium balance, if they received saline, was positive 150 or 300 millimoles. I told you, you only need 1 millimole per kg per day. So 300 millimoles for a 70 kg person is a lot of sodium already. So the sodium balance being positive resulted in a fluid balance being positive. So also the healthy nurses gained weight due to positive fluid balance, 600 cc. In the ICU, 1 liter after 2 days. Of course, the healthy nurses will evacuate the excess fluids, but in the ICU, patients may accumulate and accumulate further fluids. And that's why in Belgium, we don't have a lot of wine, but we do have beer. I hope it's okay that I show beer. I'm not making publicity, but it's a nice Belgian beer. They always give the salty peanuts. So the beer hypotonic, with the salt becomes isotonic. So 2 things. You're more thirsty, you drink more beer, and because of the tonicity, you stay at the bar and you don't have to go to the toilet to urinate. So it's a win-win. You stay at the bar, you're thirsty, and you drink. Win-win for the barkeeper. So that's why they give the salty peanuts. So the key concepts that we know from antibiotics, which are the pharmacokinetics and the pharmacodynamics, where you have the drug, the host, and the bug, you could translate it to the fluid, the overload, and the shock that needs to be treated. And if you give IV fluids too much, you get fluid accumulation syndrome. If you give too little, the patient will have tissue hypoperfusion. But as long as you're infusing fluids, and these are studies by Robert Hahn, you have a volume expansion effect for crystalloids and colloids. So in cases of patients with shock or anesthesia, hypotension, colloids and crystalloids may have the same volume expansion effect. In shock, excretion is low compared to healthy volunteers. And you can see that distribution compared to healthy volunteers is also different. So as long as you're infusion, you will have a volume expansion effect. So the pharmacokinetics dynamics are important. Brings me to D6, duration of treatment. We should not give fluids to treat the numbers, not because blood pressure is low, CVP is low, because the patient is fluid responsive, because we are all fluid responsive, yet we are not having a fluid drip. And we should only give fluids to treat shock with lactate, DO2, VO2 imbalance. So D7 is about de-escalation, and this brings me to the ROSE concept, where you have the resuscitation phase, very early stage of shock, minutes, save lives, optimization phase within hours, stabilization, so you support organ function, and then evacuation. Most patients will evacuate spontaneously. This we will discuss later on, but it's like the ROSE acronym, resuscitation optimization. It's like giving water to the flower, the rose, and it blossoms. Just at the end, it's a dry rose. It's not a dead patient, of course. And I'm very happy to see that other colleagues, like in neurocritical care, are taking over the ROSE concept. And you can copy-paste it to any condition, like in burns, like in pancreatitis, sepsis, and so forth. Because it's all about choosing the right targets and safety limits and triggers to start in order to reach the goal. The goal is tissue perfusion, but avoiding global increased permeability syndrome, avoiding the Michelin man. So, global increased permeability syndrome is a patient that has a persistent positive cumulative fluid balance, capillary leak, and organ failure. Some patients are swollen up, but they are breathing with 1 liter of oxygen, they are doing fine. Those are okay, you just wait. But the ones who have capillary leak, high lung water, low PF ratio, needs probably some help. It may also be a biomarker for severity of illness. The more fluids you accumulate, the sicker you are. So it could indicate that source control is not good, and you need to ask the surgeon, do a CT, change the antibiotics. But the positive fluid balance, many studies show, is an independent predictor of outcome. And restrictive patients usually do better than the ones who are treated liberally. Okay, this is a bit messed up, but it just tells you that fluid overload has an impact on all organ functions. And if you see this, when you go back tomorrow to the ICU and the family asks you, what's wrong with granddad? He's a bit puffy, swollen up, edematous. You're not gonna tell them, oh, it's nothing to worry about, it's just cosmetic. No, you're gonna tell them, it's not cosmetic, it's a problem, we noticed it, and we are looking into the matter, because maybe there is poor source control. So peripheral edema is a biomarker, and if you leave it, it may be bad medicine. D8 is about the documentation, and that's for the pharmacist mainly, to look at the consumption or to look what you're doing. And this is from Johnny Wilkinson. He did a medical audit, and he found that internal medicine patients received 9 times too much salt. And the daily needs for potassium were not covered. Too little potassium. You probably know where this is. This is the Little Mermaid in Copenhagen, Denmark. In Denmark lives Anders Perner, one of the principal investigators of the classic trial. And he looked what the pharmacists in the country were delivering. And this was astonishing. So 1.5 million liters of isotonic fluids, and almost 70% of these was saline, 70%. If you would ask the doctors in Denmark, are you giving ringers or balanced? Everyone would say yes, of course. But if you ask the pharmacist, is the only person that really knows, the majority is saline. This is beautiful. You probably, I didn't know where it was, but it's Fife in Scotland. And in Scotland lives Marsha McDougall. And she is the first to publish the implementation of the NICE guidelines on fluid stewardship. And by implementing, they saw a decrease in saline. They saw a decrease in Hartmann because they used Plasma-Lyte. Ringer's lactate is a little bit hypotonic. So if you want to use it for resuscitation, it's not ideal, I would say, and Plasma-Lyte has a higher tonicity. They increased hypotonic balanced maintenance solution when needed, and they were able to reduce costs, 80,000 pounds annually, and they reduced the fluid per day, per bed occupying day, from 0.65 to 0.4. I think now they are at 0.3, and from 5 liters, I think now they are at 3 liters per patient. So you can reduce fluids, reduce complications, reduce costs. And this is something that the chief medical officer or the finance director usually likes very much. This you may not know, but it's the Atomium building from the World Exposition in Brussels, in Belgium. And when I was the head of the ICU, we started with fluid stewardship, and you can see that the liters per patient came down from 3.8 to 1.7 at the last semester, and to 0.3 per day. So it's a bit similar to what Marsha McDougall. We started at 0.6, which is also a number that comes back often in many hospitals. So it is possible, but you need to look at the numbers. So the clock is ticking, and we can do better, and what we should do is this diligence, carefulness of looking at fluids. And you know the stewards in Belgium at the soccer field, so we should implement fluid stewardship. And a possible definition, in analogy to antibiotic stewardship, is a series of coordinated interventions introduced to select the optimal fluid dose duration of therapy that results in the best clinical outcome, prevention of adverse events, and reduction in costs. So it's all about the right fluid, right dose, right rate, speed, duration, indication, patient at the right time. So only when needed, only when there is an indication to give fluids. So this, what I talk here, is also summarized in this paper. It's also open access, and I think it's one of the most cited and downloaded papers of Annals of Intensive Care, with a very high Altmetric score, and it's still #1 of all time. So again, showing the eagerness of healthcare providers to learn more about fluid stewardship. So the last part is about discussion, and which is the most difficult part. It's the change, it's the transformation, the mindset of the doctors. And how to do so is summarized in this open access paper on implementation of fluid stewardship. And it takes you to a cycle of 13 points. where you start identification of the clinical leads. And I think for Kuwait, we have identified a pharmacist, a doctor, a nurse. With this team, you then start to establish further the core team. It should be ER, OR, ICU, ward doctors, pediatricians, pharmacists, and so forth. Then you determine your objectives. You do the baseline snapshot. You check at your KPIs. You can bench with peers and internationally. Then you do the survey, like I showed you, with doctors and nurses, a medical audit, look at the appropriateness of the fluid prescription, determine your change objectives, and then you coordinate the clinical pharmacist, you write your proper guidelines, and you launch with an awareness week the fluid stewardship. So it's with a startup phase, then you have the knowledge phase, testing phase, the strategy, and then the preparation and implementation of the fluid stewardship program, which then, as a regular cycle, plan, do, check, act. So to wrap up with this introduction, I hope I convinced you that IV fluids are not just innocent bags of water. They are not. They are really drugs, medicine. They come with indications, contraindications, potentials, adverse events. So consider them and only give them when they are needed. The best fluid may be the one that has not been given unnecessarily. If it comes to fluids in sepsis and ICU, there is no place for starches, gelatins, hypotonic solutions, saline in large amounts. So for resuscitation to save lives, isotonic balanced solutions are a good first choice. Think about the saline in TBI patients, upper GI losses. Maintenance, usually not needed because you have a lot of fluid creep. If needed, give hypotonic balanced maintenance solutions. Avoid fluid creep. Avoid too much sodium and too much chloride. The fluid strategy may be more important than the fluid itself. Also, sepsis, AKI, DKA, balanced solutions. Is there any nephrologist in the room? Nephrologist. Okay, so we can speak freely. Because nephrologists, when they see a patient with AKI and increased potassium, they have a reflex saline. Why? Because saline does not contain potassium. They think it's going to lower the potassium. The opposite is true. If I give saline, the potassium will increase because the acidosis and because the shift from the intracellular potassium. So also in AKI with high potassium, give balance that may contain a potassium of 5. Because of the beneficial effect, it will lower the serum potassium. So we have busted a lot of myths. Training and knowledge actually is not good. Fluid overload is not yes or no, it's gradual increase. Not all septic patients are hypovolemic. They may just be vasoplegic, and with norepinephrine you can recruit. Edema doesn't mean you need diuretics. A low preload doesn't mean you need fluids. Fluid responsiveness doesn't mean fluids need to be given because you are all fluid responsive. Fluid responsiveness does not mean hypovolemia. It's just how you set the ventilator. And it doesn't mean that the patient is tolerant to fluids, so it's not a free way to give fluids. Intravenous fluids will not remain intravascularly. I told you about the saline, the hypotonics, maybe the colloids for a couple of hours. The major indication we give fluids is not for resuscitation, only 6%. But the majority is maintenance, nutrition. The fluid creep is more important. One IV bag of, I call it abnormal saline, if you allow me, is not without risks because of a lot of salt. Do not wait for fluid accumulation to be present, to start thinking de-escalation, and this we will learn during the rest of the day. Colloids are not superior to crystalloids in the shock phase. They have a similar volume expansion effect because of pharmacokinetics dynamics. Saline is not better than balanced in increased potassium. It's worse. Increased lactate does not always mean you need a fluid bolus. Continuous CVP, we didn't talk much about CVP, but there may be a revival of CVP because of fluid accumulation and right heart failure. Human albumin may not be a waste of money in certain indications like spontaneous bacterial peritonitis, large volume paracentesis, not for priming the extracorporeal circuit, but there are indications also in the late phase of septic shock. Not all septic shock patients need the 30 ml, so it's not one size fits all. The fluid balance does not need to be zero as soon as possible. Initially, you can be positive. Think about the fluid bags and pumps and drips. It's plastic. It's a lot of waste, and it's a deleterious impact on our CO2 footprint. So maybe instead of giving a bag for antibiotics, we should just give a bolus in a syringe, so we don't have the tubing and the lines. Fluids are not to be avoided in cardiorenal failure. Some patients may need it. We didn't talk about that. You are not lost without advanced monitoring, so it's nice, but also clinical science, looking at plethysmograph, doing a passive lac raising, looking at surrogate endpoints. We will learn all about this. But the implementation of a fluid stewardship program will preserve your knowledge basis. And this will keep us intelligent. Not because you think you know everything without questioning, but rather because you question everything you think you know. Just relax. 3 statements. First, I told you we will have a group photo at the end of the day with you all here, so I'm just preparing. And in this photo, you see, we always have 3 stages. First is serious. Everyone serious? Then we have the thumbs up. In Indonesia, they also have, I thought they were showing me the money, but it's a heart. And then the last one is a crazy one, as you can see there. So be prepared. I will sign some books, and they are over there. But these books, you can only win if you take the exam at the end of the day. Oops. I'm stuck. Can you go further? A slide? Is possible? Or the presentation is blocked? Okay, so it was just, I will sign the books. At the end, you have to take the exam. Okay, these are the books. Take the post-test. And then
Dr.
I would like
Niels
to,
van
can we have the
Regenborrel,
noise? The
an
sound?
internist and intensivist from Antwerp, Belgium,
Sound?
introducing the basics of fluid homeostasis in the first session of the International Fluid Academy's basic course on fluid management. He emphasizes the importance of understanding why intravenous fluids are prescribed, the physiological mechanisms behind fluid balance, and common misconceptions in clinical practice. The Fluid Champion course is coming soon. The first modules on the basics of fluid management are launching this September, and they are completely free. Don't want to wait? No problem. Join our free members portal by clicking the link and start taking the first steps to becoming a fluid champion today. See you there.
So this was a preview of the basic Fluid Champion course. If you just sign up as a member, you can take the course free. And this is the first step if you want to become a center of excellence. Identify a team, 2 doctors, nurse, pharmacist, dietitian, take the course, and then attend like an IFAT meeting over here. Can you move on to the last slide? I think we are just there, and the last slide is to join the International Fluid Academy. Thank you, and welcome to the IFAT Mini Kuwait. So it's my pleasure now to introduce the next speaker, Professor Xavier Monet, and he will tell you everything about hemodynamic monitoring and assessment of fluid responsiveness. Xavier, please.
And of course, the first treatment is to give fluid. Let's give a fluid bolus. However, what is this concept of fluid responsiveness? Why do we give fluid to our patients? You will all agree with me. Basically, we want to increase the mean systemic pressure, I mean the upstream pressure of venous return, in order to increase right cardiac preload. We expect that it will increase the preload of the left ventricle and that eventually stroke volume will increase. We expect it will increase oxygen delivery and tissue perfusion, which is not the same as you know, improve cell oxygenation, increase ATP production, and reduce anaerobic metabolism. This is what we expect from fluid administration, okay? You will all agree with me that the first step after increasing cardiac preload is an increase in cardiac output. I mean that basically we give fluid to increase cardiac output, not for increasing arterial pressure, by the way. And if fluid does not increase cardiac output, it cannot exert any beneficial effect. The problem is that the relationship between the cardiac preload and stroke volume from the experiences of Starling is this one. And we are used to look at it on this direction, on this, and we know that it's not a linear relationship. And we know that the slope of the relationship depends on cardiac contractility. And that's very important because, in fact, when you give fluid to one of your patients, you play with this relationship between preload and output. I mean that you increase cardiac preload and you expect that cardiac output and stroke volume will increase as a result, okay? So that's why I'm saying you play with this relationship at the bedside. And you easily understand that the effect of a fluid bolus cannot be constant. It's been demonstrated by many studies. We reviewed only the most recent one with Antonio Messina and others. When you look at the studies, when you give a fluid bolus, it increases cardiac output in only half of the cases. You give a fluid bolus in a critically ill patient, cardiac output will increase in only 50% of the cases. And this is obviously due to the slope of the Frank-Starling curve. You easily understand that if the slope is reduced, either because cardiac contractility is reduced or because the patient's heart is working on the right side of the relationship, you will increase cardiac preload with fluid, but cardiac output will not increase. One says some patients are non-responders to fluid infusion. It means non-responders in terms of cardiac output, okay? And again, that happens in half of the cases. Is that a problem? I mean, is this a problem to give fluid to a patient who will not respond to fluid? Yes, because in that case, fluid will not exert any beneficial effect, but will increase the fluid balance. And we know, and it's been introduced by Manu Balbrain just before, we know now all the adverse effects of giving too much fluid on different organs. It increases lung edema, increases abdominal pressure, increases CVP, induces hyperdilution, and likely the most severe effect is to increase lung edema in case of respiratory injury, of a lung injury. And as a result, many studies have shown today that the higher the fluid balance, the poorer the outcome of the patients. giving too much fluid is dangerous. So it means that eventually we are left with two elements. The effect of fluid is not constant, and fluid infusion is potentially harmful. And this is the reason why we should try to predict fluid responsiveness before giving fluid. I mean, before I give a fluid bolus, I want to know whether it will be efficient or not. I do not want to give fluid to a patient where it will not be efficient. This is the concept of predicting fluid responsiveness. Then, okay, let's predict fluid responsiveness. How to do that? How can we test fluid responsiveness at the bedside? And the right way to do that is to do it dynamically. This is what we explained in this review in intensive care medicine with Professor Malbrain, with Professor Pinsky. You will change preload in any way, spontaneously with a ventilator, with a passive leg raising, etc. And look at the change in cardiac output and stroke volume. And if cardiac output increases significantly, it will mean the slope is steep and your patient will be fluid responsive. And today, for changing preload, for testing preload responsiveness, we have different tests and indices that are available, that have been developed for this purpose. Some of them use the ventilator and some mimic a fluid challenge. That's the list of the tests we have. And in the next minutes, I suggest that we review these tests and indices. What's the degree of demonstration? I mean, do we have many studies or not? Is the test reliable? I mean, in terms of sensitivity, specificity to diagnose fluid responsiveness. Is the test easy to perform in practice, which is, of course, important at the bedside? Can we use it in many patients? What is the applicability? And very important as well, is it possible to perform the test without an invasive, a costly monitoring device? Let's do that in the next minutes. The easiest way to test fluid responsiveness is this mini fluid challenge because it's very easy to perform. The principle is very easy to understand. You will not give the whole bag of fluid, the 500 milliliter bag. You will give only 100 or 150 milliliters of fluid. And if cardiac output increases significantly above a critical threshold, you will give the rest of the bag. The effect of a small part of the bag predicts the effect of the rest of the bag. Okay. It's quite reliable, but there are two main drawbacks. The first is that different diagnostic thresholds have been reported. These are 2 meta-analyses, and you see that the diagnostic threshold, I mean the percentage increase, the percent increase in cardiac output or cardiac index that defines fluid responsiveness is not the same. 5%, one doesn't know. Likely we need more studies. And the second drawback of this mini fluid challenge is that you need a very precise measurement of cardiac output, and it's easy to understand why. That's the first study that describes this mini fluid challenge, and they used echocardiography to assess the effects. You will all agree that if you give a small amount of fluid, the increase in cardiac output will be small. It means that the technique you use must be precise enough for detecting a small increase in cardiac output. And I'm not sure that echography can do that precisely. Echo is not very precise. In this study, we showed that the smallest change in velocity time integral, you know, the estimation of stroke volume, that you can detect with echo is only 10%. If the change is smaller, it may be an error in measurement. But we showed that if you keep your hand on the patient with a sampling window exactly at the same place, then the precision is increased, and the smallest change you can detect is 4%. It has a very practical consequence. It means that if you do this, if you use this mini fluid challenge, you should do the echo, keeping the probe on the patient while someone else infuses fluid rapidly, typically with a syringe, while you measure the increase in velocity time integral to be sure that echo will be precise enough. Passive leg grazing, as you know, it is a very well-established way for testing preload responsiveness. The principle is, again, easy to understand. When you move a patient to the passive leg raised position, some blood is transferred from the legs and, importantly, from the splanchnic compartment toward the cardiac cavities, and it's the equivalent of roughly 300 milliliters of fluid. So it's and of course it's reversible, so it's a pseudo-fluid challenge. It's a reversible pseudo-fluid challenge. It's very well established. We have a lot of studies. We have meta-analysis. This test is reliable, and it's likely the reason why it has been included in some recommendations, like, for instance, the Surviving Sepsis campaign suggesting using passive leg raising to assess preload responsiveness. It can be used in patients without ventilation, in patients with cardiac arrhythmia. One must say that the test is not very easy to perform. You know, you must move the bed, you must be cautious because the patient may be extubated, you may suction ventilated patients before. And another drawback is that you cannot assess the effects of passive leg raising with a simple blood pressure, with a simple monitoring, with a simple bedside monitor with blood pressure. You need something that estimates cardiac output. So what can you use in practice? When you perform passive leg raising, so when you move the patient to the passive leg raised position, you may look at the changes in cardiac output, in pulse control derived cardiac output with a Pico, a Vigileo. You may look at changes in aortic blood flow with esophageal Doppler. It's not for the ICU. Changes in the velocity time integral with echography again, which is used a lot. Changes in end-tidal CO2, I will not speak about that in patients with stable ventilation. ET CO2 detects cardiac output changes. And you may look at changes not in pulse pressure, but in pulse pressure variation. If your patient has an arterial catheter, you may measure pulse pressure variation. And the principle is that if, while performing passive leg raising, cardiac preload increases, and if it increases significantly, the amplitude of pulse pressure variation will be reduced. So you understand, I measure pulse pressure variation with the bedside monitor and the arterial catheter at baseline. If it decreases significantly with passive leg raising, it means my patient is preload responsive, and I do not need any cardiac output monitor, just an arterial catheter and a bedside monitor that calculates PPV. In that study, we showed that if PPV decreases by more than 2 points only, the patient is preload responsive, no cardiac output, no Pico monitoring, no cardiac echo. PPV once again, the first way that has been described to assess preload responsiveness. And the principle is simple. Ventilation changes cardiac preload cyclically. And so if this cyclic change in cardiac preload changes stroke volume or pulse pressure significantly, my patient is likely preload responsive. If pulse pressure variation is significant, above 12%, it means my patient or the heart of the patient is working on the steep part of the Frank-Starling relationship. It is very reliable. Many studies have shown it is a good way to test preload responsiveness. No need for any monitor, it's calculated automatically by bedside monitors, no cardiac output monitoring, but the main drawback is that it cannot be used in many cases. In patients with cardiac arrhythmia, in patients with spontaneous breathing, and in patients with low tidal volume and low lung compliance, it means in patients with ARDS. So you see, in all these situations, you cannot use passive leg raising, and it's likely a very large proportion, perhaps 90-80% of ICU patients. PPV cannot be used in a majority of our patients. That's why this tidal volume challenge is interesting. The principle was described in this study we performed with some Indian colleagues in Mumbai. You ventilate a patient with a tidal volume at 6. As tidal volume is low, pulse pressure variation has some false negatives. VT is not enough for stressing the system, you understand? PPV will be too low. You increase VT from 6 to 8 milliliters per kilogram of predicted body weight, and you look at changes not in cardiac output. No cardiac output monitoring is required. You just look at changes in pulse pressure variation again. You measure the change, the increase in PPV, and if PPV increases significantly, your patient is preload responsive. And of course, then you decrease VT back to 6 milliliters per kilogram. It is reliable even though different thresholds have been reported, meta-analysis published quite recently, and you see that the changes in pulse pressure variation vary from 1 to 4%, so perhaps we need more studies to know what defines positivity. I told you it's easy to perform. The patient must be ventilated, of course, but you need no cardiac output monitor. So in practice, you just measure PPV with your bedside monitor in the arterial catheter. You increase the tidal volume from 6 to 8 milliliters per kilogram, for instance, for 1 minute. You look at the increase in pulse pressure variation. If it increases by more than 5 or 4%, the test is positive. And perhaps, if the risk is not too high, you think about giving fluid after having reduced the tidal volume. That's the practical way to do that. Vena cava variations, a very popular way to assess preload responsiveness. Nevertheless, this is the least reliable method we have for testing preload responsiveness. It has been demonstrated by many small studies and their meta-analysis. It has been demonstrated by this large study. You see, the area under the RAC curve for the inferior vena cava variations was only 0.65. That's bad. IVC changes do not reliably indicate preload responsiveness. And the reason is likely that it's not a pure marker of preload responsiveness. What do I mean? Have you already thought about why the IVC diameter, the inferior vena cava diameter, changes in case of preload responsiveness? It's not that easy to understand. Likely it's because the intramural pressure, the central venous pressure, changes with ventilation in case of preload responsiveness. But obviously, this is also influenced by many other factors, and the first being the intra-abdominal pressure. but also the vein compliance. So if the vein is full, it is less compliant than if it's empty. So you see, not a pure marker of preload responsiveness. IVC changes are not reliable for testing preload responsiveness. In addition, many people miss that it shares the same limitation as pulse pressure variation, plus intra-abdominal hypertension. The end expiratory occlusion test. You've perhaps heard about this test, which is indeed very easy to perform and also very easy to understand. Your patient is ventilated. Each insufflation will decrease cardiac preload. So you inflate the lungs, and so it impedes venous return at each time. So if you stop ventilation for a few seconds, finally cardiac preload will increase, the right cardiac preload. And if you wait for a long time, and likely 15 seconds are required, it crosses the pulmonary circulation. The left preload increases. And so if stroke volume, cardiac output increase, it means your patient is preload responsive. So you understand? You stop ventilation at end expiration for 10, 15 seconds and look for an increase in cardiac output. So my patient is ventilated cyclically. I stop ventilation and airway pressure decreases at the PEEP level. I keep it for 15 seconds, so it's quite long. And some patients do not tolerate this pause, so they breathe again, unfortunately. I look for an increase in cardiac output, and the threshold for positivity is 5%. If cardiac output increases by more than 5%, the test is positive. I start ventilation again, and I may consider giving fluid to my patient. Okay. It is reliable. We have many studies today. That's a meta-analysis we have performed. You see the nice area under the RAC curve, 0.95, much better than IVC changes. And the threshold for positivity is quite homogeneous among studies. You can do that I do not have time to show that, but just with echo. The easiest way is to use pulse contour analysis with a Vigileo Pico device. But you can do that with echo, with the amplitude of the SpO2 signal. But the main problem is that some patients do not tolerate, I told you, the 15-second end expiratory occlusion. They interrupt the hold because it's long, 15 seconds, if they are not sedated. This is the reason why we have developed the last test, this PEEP test. Because there is only one study that has been published quite recently in Critical Care. Our patients were ventilated with a PEEP level above 10, mainly ARDS patients. And we decreased PEEP from more than 10 to 5, so it's a PEEP decrease test. So cardiac preload increases. If cardiac output increases as well, it means your patient is preload responsive. You understand now? And we showed that indeed in preload responsive patients, these are the blue patients, I show you in a bigger size, cardiac output increased more than in preload non-responsive patients. So you understand? PEEP more than 10, I decrease PEEP to 5, I look for an increase in cardiac output, and the threshold for positivity was 9%. And the gray zone, this zone of diagnostic uncertainty, was low. Okay, likely we need more studies. It's only one study. There are some studies performed currently for confirming that. We used a Picker device for testing the test, but it's also possible just, again, with pulse pressure variations. Quite an easy way to test prelude responsiveness if confirmed. So to summarize, if you understood well, my preferred tests for assessing prelude responsiveness are passive leg raising, because it's very well established, but not very easy to perform. The tidal volume challenge is interesting because you need no cardiac output monitor, but we have this problem with the diagnostic threshold. And expiratory occlusion, very well established, but impossible in some patients who interrupt the hold. And the PEEP test, if confirmed by further studies. Thank you very much for your attention.
So I prepared some questions with ventilator. So I'm going to get my computer here. Can you connect this one? Xavier, you can already take questions, eh? So yes. Yep.
Do you have questions on the both presentations? Yes, please. Isabelle, speak. Yes, thank you. Very much.
For passive leg raising, any age specific, like neonate or 2 months, 3 months of age, like will be the same validity for 5 years or 6 years? Because this like 300 ml will come like a bolus for passive leg raising. So biologic will be for small age, will be less or not the same action for this. So any age specific, less than this age not to be valid, or any age can be?
Thank you very much for the question. Indeed, in children, the volume of blood transferred is likely smaller. There are some studies, but in quite old children, not in very small babies, I think. It's been tested in some pediatric studies around 10 years old or something like that. I'm not a pediatrician, but it works in quite old children. Likely, in fact, the threshold for positivity may be different, okay? But it can be used in this quite old children. You work in a pediatric ICU, if I understand. Otherwise, you would not ask the question. First, and then you. Yes.
Now we're asking, why did we call normal saline normal? So my question now is, why we are calling balanced fluid balanced?
Why?
Balanced fluid is balanced.
Why do we call that balanced fluids, right? Perhaps it's a question from Manu, but likely because these are more physiological fluids, in fact, more.
Well, that's what we said about normal saline in the past.
Yeah, sure. But as you know, normal saline is not balanced, in fact.
Now.
Now,
Yeah.
you mean?
I mean, it's been called for years as normal saline. Now we don't say, no, it's not normal. It's
Yeah,
not
sure.
normal.
Sure,
it's
absolutely.
saline. So why do we call balanced fluid now as balanced? So in the future, somebody will say, no, it was not balanced.
Okay. Why do we? Yes, okay. In the past, we said it's normal saline, and now it's not normal saline. Today, we say balanced solutions, but in the future, we may say, no, these are not balanced
We
solutions.
were mistaken, sorry.
But we don't say normal balanced solutions. We just call them balanced
Well, I mean, the same thing.
because there is a buffer. You know, so there is a buffer. There is acetate, there is gluconate, so whatever you call that part, it has a name, and we decided to call it balanced or buffered or...
But to go further, there are different balanced solutions.
Yeah, of
so
course,
it means
of
that
course.
some are more balanced than other ones.
Absolutely.
about
So
buffering?
I prefer buffered.
Not balanced.
Not balanced, so there is something which is creating a strong ion difference. either gluconate, acetate, lactate, malate, pyruvate, whatever
What
it is.
about bicarbonate?
Oh yeah, you could. You could. This is the highest strong.
What about the fluid like dextrose and bicarb?
But the problem is that to administer bicarbonate, you have sodium bicarbonate, and there is a lot of sodium as well. That's a problem.
You can dilute it in 750 ml of dextrose, and you call
Probably,
it also
yeah.
balanced.
You have the CVVA solution, the 5-liter bags that come 2 compartments, bicarbonate, and then the others. And just before using it, you break the seal and you mix it. That content most closely resembles plasma of electrolytes of but you're right. Maybe we will talk about other things in the future, but I think it would be good not to call it normal saline, just call it saline. That's what it is, yeah, 0.9 saline, yeah.
So my question is, I saw many methods to see the fluid responsiveness, but why there was no echo ways to see the fluid responsive, like SV, stroke volume changes after the fluid infusion, like LVOT into VTI, like stroke volume variance. That method was not seen, like cardiac output monitoring with echo, transthoracic echo, which can be used in all patients, which we use in our ICU. I didn't see that as an option for that, that's what.
Meanwhile, can everyone already take the phone, go to menti.com and enter the code, and then you should see the screen. So we wait for everyone to join. We can't reach the Sorry? You can't see the QR? No, but if you go to the browser, menti.com, and then you enter the code 43464642. I could try to move this, but I think it's not movable. Okay, take a browser, Firefox, Safari, Chrome, whatever you want, menti.com, and then the code. Okay, Xavier, you can take the question.
It's a very good question. Indeed, your question was, is it possible to use echo, right?
The question is why that was not shown as a method to see the fluid.
Yeah, no, but it's not echo. Echo is just a way to measure the changes induced by these tests. So, for many of them, you can use echo. That's what I said. It's not to test echo, it's just a way to measure it. So, you can use echo for the mini fluid challenge, I told you. You can use echo for passive leg raising. You can use even echo for the PEEP test or for the end expiratory occlusion test. Most of them, but be careful, echo is not very precise. And that's the big limitation. So you cannot trust small changes in velocity time integral, but as you said, it can be used with the majority of the tests, indeed.
Yeah. Oh.
Thank you so much for your presentations. My question is, in emergency department, is the concept of fluid responsiveness is applicable in emergency department? And what's your preferable test as a most reliable test in emergency department and most easy as well?
It's a very good question. Thank you. 2 points. The first is that be aware that at the very initial phase of septic shock, all patients are preload responsive, very initially, okay? All of them, because they are hypovolemic. There is relative hypovolemia, there is absolute hypovolemia. So initially, likely it's not needed to assess preload responsiveness. But if the patient stays for, let's say, 1 liter, 1.5 liters in the emergency room, then you need to test preload responsiveness. Second point, which method, and to measure cardiac output, which test? It's not easy. The best way is likely to use cardiac echo because it's available there, and passive leg raising because the patients are often not ventilated. But I must agree it's not very easy to do. perhaps that may be an indication for non-invasive cardiac output monitors. Perhaps you know this bioreactance device, just 4 electrodes you paste on the thorax and you have cardiac output. And that's much easier than echo. And perhaps one indication could be for the patients in the emergency room. One study in the US has used this method in the emergency room for performing passive leg raising, for instance. That may be an indication for these non-invasive methods, perhaps, if you have them. Without these methods, the best way is likely cardiac echo and passive leg raising.
Yep. Okay, so let's take the voting. So most of you are from here, Kuwait. I'm from Europe, 2 from Africa. And most of you are doctors, but I'm very happy to see that a lot of nurses, because the nurses are the ones that are putting the bags to the patient. And sometimes there is even no prescription. So they just have to take a bag as per protocol or per guideline, or just because they need to administer other drugs. So no tourists, okay. Are you anesthetist, internal medicine, emergency? So we already know there are no nephrologists, yeah? Or maybe there is a nephrologist, but he is very scared because he is giving saline to patients with increased potassium. Anesthesia, majority, pediatrics, very good. It's very important. There's a lot of debate on fluids in pediatrics because of the risk of hyponatremia. So still some isotonic solutions given there and saline. All right, so it's a good mixture. No surgeons. I think surgeons are important. They are key for fluid stewardship as well. Okay. So how many years of experience? If you're still a medical student, but I don't think there were any medical or nursing students, you can take 0. So more than 20 years. Whoa, there's a lot of experience in the room. Excellent. Okay. So I'm sure the exam at the end will be brilliant. Yeah, everyone will pass with such kind of experience. Okay, great. So is this your first IFAT? Maybe you were there in Dubai during ECCC. So for 2 it's not a first, but for the majority it is. Are you enjoying so far? I don't hear it. Yes, okay. Now, the crucial question. Have you implemented fluid stewardship? I assume most of you have not, but I hope that many of you will do so in the future, or maybe you're thinking about doing it or working on it, and I hope at the end of the day you will go back home with the implementation. Okay, two have. Who voted for yes? Who voted for yes? Okay. Give them an applause. Where are you from?
I'm from Kuwait, working at Ahmadi Hospital, KOC, in the ICU.
And you have implemented the
So,
guideline?
no guidelines as per guidelines, but then that's a daily practice in our ICU to look at patient and to minimize the fluid that they give. We don't give any we don't give maintenance IV fluid as much as we can. If you are on feed, then that's your fluid, and you, as you said, you have enough fluid from the creepy challenge.
Okay. So you would like to share your knowledge and practice with the colleagues and maybe become a center of excellence then? Yes? Okay, and he was someone else, yes? Where are you from?
I am from Chest Disease Hospital here in Kuwait. We are a cardiac surgery unit, and we are facing every day this fluid challenge after the surgery. So we are involved in this.
Okay.
Yes.
Good. And I hope after today you will get some hints and tips and clues to rationalize it and uniform it so that everyone can do it in the same way. So what crystalloid fluid do you use for resuscitation? Told you resuscitation, isotonic solution. Remain intravascularly 25% after 1 hour. So be honest. Can you put in the back on H, button H for height? Is it working on the keyboard? No. The keyboard is not working. If you push H, yes. So it's a psychological experiment. If we hide the voting results, people will not see the highest vote because there is usually you vote for the highest yes. Is the fear of missing out. Okay, you can show back. Can you push H? Okay, yeah, you see. Saline, yes, come on, saline, be honest. I'm sure. But it's still, yes, saline, and it's normal. It's the same everywhere. No, what you're using now. In the future, of course, you will use balanced, except for TBI, except for upper GI losses. So, but yeah, this looks good. Looks good. I'm sure some voted Ringer, except the fact they're initially saline, I think, yes. All over the world, even in Denmark, Anders Perner, principal investigator, 70% saline. Okay, what colloid fluids do you preferably use for resuscitation? Or maybe you don't use? Vote now. Albumin. So there is the Albios trial, SAFE trial, in a subgroup of severe septic shock patients. There seems to be a signal in favor of albumin, maybe in the late phase of shock, in fluid accumulation for de-resuscitation. So, yeah, starch. Who voted for starch? Who? You? You? Who is using starch? No, probably a mistake. In Europe, we don't use starches anymore in ICU. Maybe in the operating theater sometimes. Okay, and what maintenance solution? Can you hide the results? Because otherwise everyone will vote for the right answer. So what you're using now? Can you click on H on the keyboard? Okay, so we hide the responses. So are you using saline, hypotonic, isotonic? Glucose, sodium, potassium is an interesting solution. It's not balanced, but it's better, covers daily needs. Can you put H? Okay, so the majority, and this is exactly what happens all over the world, saline and glucose, or sometimes half saline in glucose, whereas the right solution is hypotonic balanced according to the NICE guidelines. Okay. And I think, yeah, what test do you use for fluid responsiveness? So is it mini fluid challenge or CVP, passive leg raise, PEEP test, tidal volume variation, PPV? So I see the passive leg raise, and we will learn during the skill station how do you perform it correctly, because there's a lot of mistakes that can happen when performing the passive leg. Fluid challenge, a mini fluid challenge. The problem is, if the fluid was not needed, it's in the patient. So it's fluid administration. So you're trying to predict something, but you have already done it. So my goal would be for some assessment without causing harm, without administering, like the passive leg raise. If the patient is on the ventilator, of course, and then you can have all the other tests that are quite interesting. Okay, and then what cardiac output monitor do you use? Do you use non-invasive, like a ClearSight? Do you use less invasive, pulse contour, or the SWAN, maybe transpulmonary thermodilution? I'm not sure whether the PICO is available in Kuwait, or you can have it as a version on any monitor. Ultrasound, I agree, it's the modern stethoscope, but it's not truly a monitor. It's more a diagnostic tool. you can't keep it continuously, or you have to reassess. So it's more intermittent assessment, but I believe every patient in the ICU should have a baseline cardiac monitor to see what is the function, how is the LV, RV, is there diastolic dysfunction, and so forth. Okay, so the pack is still used a lot. This is for the other round table. So I think we are perfectly on time, 3 minutes to go for the coffee break. So if there is any burning question, we can take it, either for me or for Professor Xavier, but he left the room.
I have one question. What about fluid responsiveness test during anesthesia, thoracotomy, laparotomy, or prone positioning, laparoscopic surgery? What is the preferred test?
Is a very good point. So the question is about fluid responsiveness during advanced surgery, where patient positioning is an issue. You could have like a PAC or a PICO, where you could do a calibration exactly in that position, and studies have been done. For pulse contour, you could still look at PPV, SVV, with a threshold of 15%. Of course, if the chest is open, if you have thoracic surgery, open chest, then PPV, SVV are low and you can't use them. But you can turn it around. If PPV, SVV is high in an open chest, where you expect it to be low, then again, it may tell you that this patient could be fluid responsive. Other non-invasive parameters are pleth variability index, PVI, saturometer, you look at the wave, so this could also be interesting tests going from completely uninvasive, less invasive to invasive. So. Yeah, in these different positions, you can look at the same test. So if you expect them to be low, like in an open chest, in a different position, and they are high, they will tell you something about fluid responsiveness. So you could use the same test with the same limitations. Of course, they go arrhythmia, tidal volume, spontaneous breathing, all these may interfere with the interpretation. But if you have an invasive device, calibrated, like thermodilution, then, of course, you can do a calibration during the surgery, and then you have kind of a gold standard cardiac output monitoring then with all the derived parameters. I'm not sure whether a passive leg raising or positioning or Trendelenburg is possible during surgery. Probably not, so I would say PPV.
I am an anesthesiologist, and for testing for fluid responsive during the anesthesia, it's a challenge. But if we keep the minute volume fixed, we can trace the end-tidal CO2. It will give us a very clear trend regarding the cardiac output going down or increasing or decreasing. And according to the circumstances in the surgery, there is blood loss, there is extravasation, there is evaporative loss, whatever. We can, from all this data, we can say that the patient need more fluid or no, without changing the position, without invasive. It all comes with the end-tidal CO2.
And maybe the CO2 gap. The difference, you can have probably an A-line, you can have the arterial CO2 and look at the
delta CO2 can also check.
Yep, to check for the gap is increased. Yep.
It's a good point, but your patient must be very stably ventilated. No spontaneous breathing. So in anesthesia, and it's been shown in some studies, we did it first with the end-tidal CO2. If it increases by more than 2.2 millimeters of mercury during passive leg raising, and by more than 3 during a fluid bolus, it means that cardiac output has increased. That's a good point in the operating room, indeed.
But in the operating room, you could also do the tidal volume variation test. You could go from 4 to 6 to 8 and just look at the PPV.
Yes, also if you have an A-line.
You have minute volume and you have end-tidal CO2. Fixed minute volume, patient under muscle accent, and the end-tidal SUSI changing, this is a direct relation with the cardiac output. No need to initiate another test. That's what I'm saying, from my experience in anesthesia. Keep also in your consideration that you're looking at the blood loss, at the whatever fluid loss is there, and then according to this you will see. You want to give more fluid, you want to reduce the fluid, like this.
Fully agree. Oh, here.
What are the tools available for de-escalation? Is it Lasix, CVVH, renal replacement therapy, restriction of fluid? So what do you mean exactly by de-escalation?
It's a very good point, and this we will deal with after the coffee break. I will give you all the definitions and all the ways for prevention with restriction, withholding, the care of the patients with the monitoring, perfusion, optimization, and the cure with de-escalation, which is lowering the volume or the speed, or fluid withdrawing. So you have fluids running, you stop them, and then the medical treatment with furosemide stress test, and the mechanical treatment with CVVH. So we will give an overview of all that, and Xavier will tell you how to limit or avoid the positive cumulative fluid balance.
Hi.
Okay.
Thank you for the nice presentations. I work in the pediatric ICU. So I just wanted to ask for diabetic ketoacidosis, because most of the guidelines recommend normal saline. So what fluid will you recommend?
So balanced crystalloids, there are some meta-analysis, also from the RELIEF trial. There is a subgroup on DKA, and I think the guidelines are shifting. Some of the diabetology guidelines are already introducing balanced solutions. Most preferred one, I would say, is something with a tonicity close to normal. So Ringer is a little bit low, so more in the range of Plasma-Lyte with a little bit higher tonicity than Ringer's lactate. But the guidelines are shifting, and they are going towards balanced crystalloids for DKA, and that's why we mentioned it. If you want, we can share some of the recent publications where you can find this, yeah, as well as meta-analysis. So there is a faster resolution of the ketone body, so the acidosis, and there is a shorter length of stay if you use balanced compared to saline.
Thanks.
Okay, so I think we are on time. I thank you for attending. So we have the coffee break, and we will be back at 11:15. Okay, enjoy the coffee break. See you later.